Sorry, what's your hashtag?
Hashtag PHFest 2021.
I'm going to press start webinar now and let people in.
Welcome everyone. Good morning, good afternoon and good evening. We're very pleased to welcome you to our International Festival of Public Health. And I'm just going to go through some housekeeping. My name is Arpana Verma and I am the Director of Much, and we are your hosts. We're going to be using our Twitter handle of hashtag PHFest 2021, and we'd be very pleased if you would be able to tweet. So as many of you know, this is the 9th year of the International Festival of Public Health, and we're very pleased that we are able to welcome the friends of the festival and all of our special speakers for both the plenary, the special sessions, our poster sessions, and the oral sessions that are in the programme. The website has all of our details, as well as the start times of each of these sessions. The programme at a glance is there for you to use as the start times of each of our different sessions. Please note that the approximate timings are the plenary sessions have approximately 2 hours. Our special sessions are 1.5 hours. Our parallel oral sessions and our poster sessions are also 1.5 hours. So on the programme at a glance, these are the indicated start times only. When you scroll through our Articulate Rise programme, you'll be able to see all the details of the timetable, including the biographies of our speakers. I'd like to remind you of the Zoom etiquette. Please keep muted with your camera off unless you're speaking. We have some very exciting, as ever, prizes. And this year, we're reliant on you voting using our electronic platform. The prizes will be for the best oral and poster presentations, and the chairs of your session will give you details. The plenary sessions, you have the ability to use the questions and answers session. You can also tweet us, and we are recording or streaming this live onto YouTube. Please have a look at our programme on the website, as we have an ever-evolving set of speakers as we try to cram in all of the late breakers and any of the interesting things in this time period that we have with you at the festival. If you have any issues, our team will be monitoring the Much at Manchester email account. I'd just like to quickly tell you about our centre. We have the Epidemiology and Public Health Group that's part of the Division of Population Health, Health Services Research and Primary Care, that is also made up of 5 other centres. Much, which sits in the Epidemiology and Public Health Group, has been doing real life world evidence for research, and we are very proud to have some of the people that we've been working with here at the festival. We will be showing you some of our research in the sessions over the next week, but we also are very teaching intensive and believe the true ability of having research-led teaching is the success of our teaching programmes. As well as the open access courses, we run our Masters of Public Health and our brand new sister programme, the BSc in Public Health, that is accepting applications for this year. Here are some of the team, and without them, we wouldn't be able to do any of the activities. And one of the core activities that we wanted to talk to you about is the work that we've been doing on poverty alleviation. And this was part of a UK PRP consortium development grant. We are so proud of the consortium that we built, and these are some of our partners. The whole point of Prior was to look at how we can try to work out what strategies and interventions can help us. We have the tsunami of the pandemic, also the global crisis from the pandemic, as well as all the other things that are happening in our areas. We chose 3 areas, and we chose the ability to look at financial, digital and health, and how these can be co-produced going forwards. We wanted to have a look at some of the achievements of our consortium development grant, and here was a survey that we did across our 3 areas, and the key point was really this inextricable link between health, digital literacy and financial literacy. We also did a significant amount of photo elucidation work where we asked our residents what they thought, as well as some of the key components of the assets that they had in their communities, because the core behind Prior was to co-produce with our communities and be able to think through what they need, how they need it, and what the best interventions are to help them. The reason for talking to you about it today is because we're looking for new partners. And if you're interested, we would welcome any emails to much@manchester.ac.uk. So we hope that you will enjoy our programme, and if you have any issues, please can you have a look at our website and email much@Manchester. In terms of the programme, I'd like to start by thanking the team for bringing such a marvellous programme together. And we're going to start our plenary session with a friend of the festival and also a long-time friend of our urban health projects that started with Dick Heller and Chris Burt back in 2006. So I'd like to give the session to Dr. Iveta Nagyova. Over to you, Iveta, and thank you so much for agreeing to speak today.
Thank you very much, Arpana. It's really a great pleasure to be here today with all of you, and also an honor. So, as Arpana mentioned, we are long-term friends, and we had a lot of initiatives together in the field of urban health. And therefore, the choice of the topic of my today's speech will be directed, or will be dealing actually with urban health. But I would like to make it a bit more complex, and I would like to speak about public health, behavioral insights, and urban planning, and why we need the synergy. So why there is a need of synergy. Maybe in the beginning, I would like to shortly introduce myself. I'm the head of the Department of Social and Behavioral Medicine at the PJ Šafárik University in Košice, Slovakia, which is Košice is the largest city second largest city in Slovakia. And I'm also the president of the European Public Health Association, the YUFA. And because today I'm primarily representing YUFA here, I would like to spend a few words on YUFA. So YUFA is the largest network of public health professionals in Europe. It is basically an umbrella organization for public health associations and institutes. It has been founded in 1992. And the mission of the YUFA is to facilitate and activate a strong voice of public health in Europe. And we try to do that by visibility of the evidence, which is the basis of our work, and also by strengthening the capacity of public health professionals. YUFA currently lists 80 members from 47 countries, and we work also in 26 thematic sections. As Arpana already mentioned, she has been the co-founder and long-term president of the section of urban public health, and currently Greg Williams, another person from Arpana's teams, is the vice president of this section. So we clearly have long-term links. YUFA is trying to achieve its aims through the new YUFA strategy for years 2020-2025. And we will try to apply a AAA approach in our mission and vision. The 3 A's of the YUFA stands for analysis, which is the basis of our work, the analysis of the evidence. Advocacy, which means that we try to get the message across, and by action to make things happen. So these are 3 main focal points of our work. YUFA is trying to achieve its aims through the YUFA tools, which is the European Journal of Public Health. It's a high impact factor journal. Through the annual conference, which brings together researchers, practitioners, policymakers, educators, and trainers. Usually we have over 2,500 participants each year. So again, this is the largest public health event in Europe each year. And on the left-hand side, on the right-hand side, you can see pictures from our previous conferences, obviously before COVID-19. YUFA is also producing statements and reports on various topics touching upon public health. We have been involved in many EU-funded projects, and also we are supporting young public health professionals through our YUFA Next members or network. And currently we list over 3,000 members in our network for young public health professionals. YUFA also tries to be very active on social media. So apart from a website, we have also a Twitter account, currently with over 6,000 followers. The YUFA newsletter, which is sent out every month has 25,000 subscribers from 163 countries. And we also have 2 YouTube channels, the standard YUFA YouTube channel and also the channel from the European Public Health Conference, which I just mentioned. And here people can find some videos from the plenary sessions or also some selected workshops or some other events as well. The last activity which I would like to highlight and maybe make a little bit of promotion for the next year event is the European Public Health Week, which is actually a celebration of the public health in Europe. For 1 week, we are dealing with different topics. Every day or each day is dedicated to a different topic. And this year, it was the 3rd edition of the European Public Health Week. We have 212 events organized in 40 countries and in 19 languages. So we had a new record again in organizing quite a lot of events. So today, as I mentioned, I would like to talk about public health, behavioral insights, and urban planning, and how all this comes together and why it is relevant. And I did not mention actually in the beginning that I have been the co-founder and president of the section of the YUFA section on chronic diseases. So obviously my links will be to chronic conditions or chronic diseases. So when we look at the global health challenges, I know we are all very much focused on COVID-19, but I still believe, and one of the global health challenges is really non-communicable diseases, which are highlighted in blue. So non-communicable diseases or chronic diseases are the main drivers or the main responsible for overall mortality and also disability adjusted life years. These figures from the global burden of disease study are still from 2019 because they are not more new figures yet published at the website. But I would say that the picture, despite COVID-19, will be slightly different, but not so much, because from COVID-19 so far, 4 million people died, but from chronic conditions or non-communicable diseases, every year over 39 million people die. So this is still a very relevant problem, and it is still a problem that we need to deal with. So when we speak about non-communicable diseases, I think it's really not a surprise for nobody from the attendees of this conference, that is cardiovascular disease, neoplasms or cancer, diabetes, chronic respiratory diseases. But when we look at the disability adjusted life years, also some other diseases are coming into picture, and it's the musculoskeletal disorders and also mental health issues or mental diseases or neurological diseases. So why do we have such an increase in chronic conditions? It is because we have the interplay between various factors, biological risk factors like genetics, for example, behavioral risk factors. And again, we are talking here about unhealthy eating, smoking, drinking, and also sedentary lifestyle. Psychological risk factors are also very relevant, like depression or negative outlook. And also the social risk factors like loneliness and social isolation, which again, many people experience during the COVID-19. So all these risk factors are influencing each other, are exacerbating, and are leading to one or more chronic conditions. Or sometimes a person has developed one chronic condition, but due to iatrogenic effects of the treatment, they are developing another chronic condition. Apart from this individual perspective, we, however, have to look also at the wider health determinants. And again, I believe that this slide is not really a surprise for people working in the field of public health. So we need to put the health into a more wider context. And I'm talking here about the global ecosystem. So the climate stability, biodiversity, also natural environment like natural habitats, trees, air, water, sand, soils, and also built environment, how we are designing cities, how we are designing other buildings. This is how we are designing other streets and routes. This is all extremely relevant determinant of health and well-being. And I'm very glad that actually these issues are also reflected in the WHO Europe new European Program of Work for years 2020 and 2025. This program has 3 core priorities. The first one is moving towards universal health coverage. The second priority is protecting against health emergencies. And the third priority is promoting health and well-being. And the WHO Europe tries to improve in approximately in the lives of 1 billion people in each of these three core priorities. The European Programme of Work has several flagship initiatives. The first one is Mental Health Coalition. The second is Digital Health Empowerment. The third one is the Immunization Agenda. And the fourth one is Behavioral and Cultural Insights. And I'm specifically mentioning this one, and I would like to draw your attention specifically to behavioral and cultural insights, because it is an absolutely fascinating field. My original training is in clinical psychology, so obviously, again, there is a clear link between behavioral medicine or health psychology and public health. And for many years, the knowledge from behavioral sciences, behavioral insights, have been somehow underutilized in public health, even though it can be very efficient and very effective, and we can really do quite a lot of things. And therefore, I'm very excited that finally the WHO Europe, but also the WHO are recognizing or are turning towards behavioral insights and sciences and its relevance for the public health. So when we speak about European Programme of Work, the core three priority is promoting health and well-being. And now I'm trying again to have a link back to the urban planning. And the European Programme of Work in this core priority has 5 work streams. And the first one is supporting local living environments that enable health and well-being. So we are coming back to green cities and how we design cities. And I'm very glad and very happy that I can be, or I have been invited to be a member of the WHO Europe's Regional Directors Advisory Council on Innovation for Non-Communicable Diseases. Within this council, there are several working groups, currently 6. I'm a member of 2 working groups, and one working group is specifically on greener cities. So I would like to share now with you a little bit of background information, what we are working now as a member of the council. And the signature initiative on which we are currently working is to reduce air pollution and improve air quality within the WHO European region by urban planning to support cycling and walking and use of sustainable transport. So another thing which I would like to speak this morning, and again bringing things together more into more wider context, so to speak, I would like to share my enthusiasm for the new initiative of the European Commission, and it's the new European Bauhaus. The vision of the new European Bauhaus is to stimulate creativity, hope, and innovation to fight climate change, and using 3 principles: beautiful, sustainable, and together. And the new European Bauhaus builds on tradition of the historical Bauhaus, which was unique in many ways because it was created in in times of profound transformation. It was very visionary and very innovative, and it was promoting new materials and also was very interdisciplinary. So somehow there is an interlink between the times when the historical Bauhaus was created and the current times, which are also very transformative and very with many changes, so to speak. So the new European Bauhaus is making the new Green Deal tangible. It is a social project when we need to rethink our cities, when we need to rethink our production chains, adapt to climate risks, and improve quality of life in a sustainability, or taking into account principles of sustainability, and what I like also, style. So not only sustainability, but having things also beautiful. Then we have to rely on ecological standards and also culture and technology. So these are basically the new principles. And if you have not been or have not followed the new European Bauhaus initiative by the European Commission, I definitely recommend you to do that because it's very interesting. So how behavioral insights and urban planning and public health are coming together? Why is it relevant actually to bring them together? Firstly, as I mentioned in the beginning, the behavior or how human are behave, or the human behavior is the main determinant of health. However, if we want to influence somehow human behavior, we firstly need to understand it. And very often public health experts and politicians are making the mistake that they think that information and knowledge drive the behavior. So if we inform people that, let's say, eating unhealthy is not good for them, or eating sugary products is not good for them, people will stop doing that. But we all know that it doesn't work. People have this information, but still they are not behaving according to this information. So why is it so? It is because it is a bit more complex, and to change the behavior of people is a bit more complicated. So let's illustrate it on a principle of a COVID-19 situation, because again, this is quite clearly understandable for everybody. So for example, one of the principles was that we need to wash hands more often. So what can stop people from hand washing? Is it because they do not have the knowledge? Yes, it's one of the drivers, definitely. People have to be aware of the situation. They have to believe that hand washing helps to stop spreading the virus. Another thing is that they have to be motivated. So many people intend to act. Many people, like I mentioned in the beginning, they want to be more active, they want to be more healthy, they want to eat more healthy, they want to stop smoking, but there are other things that came into their lives. They can be too busy, too tired, or not motivated enough. So it's another driver of the behavior change. And the last one is actually the opportunity or the environment. This can be physical environment, and this can be also social environment. So what we are basically talking here about is the so-called combi model, the theoretical model of the behavior change by Susan Mickey and her team from the University College of London. And it's definitely one of the most influential models to change behavior of the people. Why is it so influential? Because it has been many years of work when they brought together this model. It was based on 33 different psychological theories, 84 theoretical constructs, 14 theoretical domains. And interestingly, it brings together also automatic and reflective processes, and I will talk about them a little bit later. So conscious and also non-conscious processes, because these things you have to tackle if you want to change the behavior. Another interesting part of this combi model and the behavior change wheel is that apart from the drivers of behavior, that means capability, opportunity, and motivation, which is the basis of the sources of behavior, it also suggests several interventions functions, so how you can change the behavior, for example, through restrictions, educations, persuasion, coercion, incentivization, training, and so forth. But it also provides possibilities for policymakers, because it also shows the policy categories, how you can change a certain behavior, for example, using fiscal measures or guidelines or regulations or legislations, or environmental planning and social planning, which is relevant for today's presentation, and communication marketing, which is again very much discussed related to COVID-19, how to communicate with media, how to risk communicate with public. So I was mentioning that this theory is very powerful because it brings together or incorporates the two interacting systems of how human beings are working and how human brain is working. So it is called dual process theory, and it has been popularized by Daniel Kahneman, and Amos Tversky, who created this theory in the 1970s. And Daniel Kahneman actually received a Nobel Prize for his work for this specific work. So what does it say? The human brain works in such a way that we have an automatic system and a reflective system. The automatic system is fast, effortless, and unconscious. And we are using this system when we are driving on an empty road, or when we try to solve the equation 2 + 2 equals, I think it's quite easy for everybody that it's 4. We, however, also have the so-called reflective system, which is slow, effortful, and self-aware. And we are using this system when we need, for example, to complete a task form, or when we need to solve the equation 17 multiplied by 24, the answer doesn't come so quickly, so we need to do a little bit more conscious activity, so to speak. So the dual process theory found that people are actually not entirely rational beings. Actually, we are very irrational, but irrational in a predictable way. And this is the key point, actually. So human beings are using shortcuts or rules of thumb, and these are causing distortions in our perception. But at the same time, these cognitive biases are very useful and very helpful because they allow for quick reactions, and they also help to deal with information overload. So as I mentioned, the authors of this theory have been Daniel Kahneman and Amos Tversky. And what they discovered is actually that cognitive biases, human beings are systematically make choices that defy the clear logic. So what is the solution for that? Or how we can bring it together with urban planning? The main point which I'm trying to highlight here is actually that we need to tackle, or we need to address not only the cognitive processes, but also the unconscious, the automatic processes. And when we speak about automatic or non-conscious processes, it's also important to keep in mind that people are the creatures of habit. So much of our lives is not governed by our conscious decision or thoughts, but basically by our habits. And some social psychologists estimated that actually 45% of our daily behavior is habitual. So what does it mean? It's a very new, fascinating, actually, field of research which links behavior with neurosciences. And Professor Anne Graviel from MIT revealed how brain functions and how behavior what parts of brains are important for role in habit formation. And actually, it is the striatum which plays an important role in habit formation. So the striatum coordinates action planning and decision-making, motivation, reinforcement, and our perception of rewards. And how it works: when we carry out a certain behavior for the first time, when we want to achieve a specific behavior, we have to engage our prefrontal cortex, which sends continual messages to the striatum. So you already know that involving or engaging prefrontal cortex is very difficult for the body. Actually, you have to put a lot of energy and a lot of concentration on performing a certain activity. However, when you want to achieve a certain habit or a certain type of behavior, this is what the brain actually is doing. And the prefrontal cortex is sending continual messages to striatum. Then striatum relies on these messages and relays these messages to other parts of the brain and enacts the messages actions and through thoughts or movements. And as we repeat the behavior, we engage the prefrontal cortex less and less frequently, and the messages are going kind of like directly already to the striatum. So when we are creating a new habit, there is a theory how it works and how we can deconstruct the loop that can reveal how to create or how to reinforce the habits, and also how to cut certain habits. So we have to understand it. What is the mechanism behind? The first thing which is very relevant is the trigger that tells the brain, the prefrontal cortex, to go to automatic mode and which habit to use. And there are 5 principal triggers or categories of triggers which are evoking certain behavior. It's the location, it's time, it can be also other people, it can be emotional state, or it can be immediately preceding action or next action. So for example, in the morning, after brushing the teeth, you go to have a breakfast or vice versa. So these are the triggers that are evoking automatic behavior. Then if a person carries it out for a certain time, it becomes a routine, and you also need an experience of the reward. So it can be either tangible, but it can be also emotional reward. And if the brain considers that it is worthy to repeat this behavior because it gives some reward to a person, then this behavior is repeated and the habit is reinforced. Another thing which is very relevant in creating new habits and when we are tackling unconscious behavior is there are key strategies how to build a new habit. And the first one is to ensure a stable and supportive environment. The second one is make it easy. The third one, develop cues and rewards. Fourth, practice and repeat. Fifth, leverage the context. And the sixth one is build meaning and motivation. And some of these strategies are essential for building a new habit, which are highlighted in red color. Some of them are important, highlighted in orange color, and some of them are good to have. So let's be more concrete on more practical. It is very often said that if we want to achieve a certain behavior in people, we have to make the healthy choices to be the easier choices. And I would like to illustrate it on one of our research studies, which was comparing the Nordic walking with traditional walking and why it is more easy for people to follow this Nordic walking. It is because there is an interesting incongruence between the perceptual and metabolic load between Nordic walking compared to traditional walking. Heart rate and oxygen consumption were higher in Nordic walking, but the subjective perceived exertion was very much similar. So basically, people were burning more energy and were involving more muscles, but subjectively, they had a feeling that they are doing a very similar activity as to traditional walking. Another example how you can motivate people to do something is to ensure a stable and supportive environment. And here I would like to highlight a case study from St. Ninian School in Scotland, which initiated something what was called the habit for the children, the daily mile, which were getting children to run a mile in a school ground each day. And how it happened, what was the trigger? The presence of the track in school grounds, which provided a stable context. And also additional trigger or cue was time of the day when children were most restless. The second one was the reward. So intrinsic, love of movement. Children love to move. And another one is also being outside with friends. And if you repeat this kind of activity regularly, it somehow becomes a standard for children and it's very rewarding for them. Another thing how we can motivate people to be more physically active is how we design our buildings. And I'm a big fan of design and architecture, so therefore I have pictures of 4 buildings. As you can see on these buildings, the lifts are not really visible, so people are immediately attracted to the stairs and are using stairs, and this is how you can motivate people to be more active. The choice architecture, we continue how we can design our shops. What we do now is to change the minds to resist the environment, but what we are supposed to do is to change the environment and make the healthy choices the easy choices. Nudging is also an option. So here is an example from COVID-19, how you can design environment. And here we have how you can motivate people to keep the physical distance of 2 meters by simple spots on the floor, or how to motivate people to wash their hands. And finally, this is actually for the future. So when we were speaking about COVID-19, the COVID-19 brought the world to a sudden standstill, but it also gave us a rare chance to think about the future we want. And there is a lot of discussion about how to build back better in more resilient and greener way. And one of the things is really to have cycling paths, to be more active, to create environments that motivates people, let's say, to walk, to use cycling to when we go to work. So finally, as I said, I just want to bring the 2 things together, the New European Bauhaus and the WHO initiative. So I wanted to share with you the most recent things that Europe is talking about, and I'm very glad that I can be part of these projects. And the final slide is that I strongly believe in synergies, and I strongly believe that the whole is greater than the sum of the parts, which this is the phrase which aptly defines the modern concept of synergy. So on the left-hand side, we have the sciences in silos. We have in silos behavioral insights and sciences. We have public health, we have urban planning. But when we bring it together in a new synergistic way, we can have a beautiful mosaic like on the right-hand side. So thank you very much for your attention. This is what I wanted to share with you today.
Thank you so much, Iveta, and always a pleasure to hear you speak. We couldn't agree with you more. And I think one of the key things from listening to you that's also been reflected in some of the Q&As is about these small incremental steps that we might use in terms of the behaviour change. So I'm just wondering about any specific advice that you have for being able to deal with things like...
Excuse me? Arpana, I did not hear you. You were silent for a few moments.
Oh, sorry, Iveta. Is that any better?
What was your question? I could not hear the last sentence of yours.
It was the question on having these small steps that you mentioned, like nudge or making the healthy choice the easy choice. And if you had any one...
Well, I can't really hear again, Arpana, she's frozen.
Oh, no.
So, but I would say that it is maybe not so simple. Actually, we also have to go beyond the simple thinking of nudging. Nudging are very interesting, but people can be easily bored. So therefore, I promoted the more complex models, the COMBI model. And my suggestion is to collaborate with people and to collaborate with other disciplines. So interdisciplinary and transdisciplinary research and exchange of ideas, I think, is the key. So there are no simple, magic bullets for anything, but I would say that we need to work in complex way, and this is the way forward to the future.
Thank you, Iveta. I've switched off my camera. Is that better? Can you hear me now?
Yes, I can.
Oh,
yeah.
Oh, brilliant. Please, would you mind having a look at the questions?
Yes.
And if you don't mind typing in your response using the type answer function.
Sure, yes, I will do that. Yeah, because we are running out of time, right? So
yes,
definitely. Thank you very much, Arpana.
No, thank you, Iveta. And without further ado, I'd like to welcome another friend of the festival. Cherian, over to you. Thank you.
Thank you, Arpana, and thank you, Manchester team, for giving me an opportunity to be part of this exciting festival. I was part of this in 2019, and the world, of course, has changed from 2019 to 2021. So I work at WHO headquarters as a cross-cutting lead for non-communicable diseases and special initiatives. So I think the previous speaker has alluded to quite a bit of issues regarding NCDs. My talk is around WHO Hearts, a game changer for NCD and PHC. Let me take an anticipatory bail. This game changer has nothing to do with any games that has happened in the recent times. So it is just a metaphor for a game changer. In addition to what we have heard, the increasing burden of NCDs is overwhelming health systems and resulting in high cost to governments and individuals. So it is not just low and middle income countries. If you look at Public Health England, where it says about diabetes, the type 2 diabetes treatment accounts for almost 10% of the annual NHS budget. That is 8.8 billion pounds a year. And they are mainly because of complications of diabetes. So that means the effective gatekeeping at primary care needs to be relooked as to why are we having, of course, the number of people with diabetes is going up, but why are we having such a large number of people ending up with end organ damage? COVID has really brought in two aspects to this. One, people with uncontrolled diabetes and hypertension and heart disease were succumbing to severe COVID and death. But more than that, the pandemic has caused severe disruption. And again, NCDs is bearing the brunt of that. So this is also a time to sort of take a priority look at non-communicable diseases as to what can be done. I think the audience knows very well that the idea of treating any of the NCDs in primary care is not just to achieve some numbers, but it is actually to prevent end organ damage in terms of stroke, heart attack, renal failure, amputation, blindness, etc. But there are many hurdles to getting this done. First of all, the diagnosis is not done. You know the rule of halves. Only 50% of people usually get diagnosed. Out of that, only 50% get treated, and out of that, only 50% get controlled. So there are areas that we have identified as lack of evidence-based, locally relevant protocol, access to medicines, simple mechanisms for longitudinal follow-up using unique identifiers, etc. Let me sort of portray it through a community situation. Take an average person in the community with a suspected NCD. Maybe there are no symptoms, or if there are symptoms, there is no money. The person then just goes to a primary care facility. In many parts of the world, it is suited for an acute care model. So usually instead of a long-term plan, person is given medications for a few days, but the medications are never complied to. And then maybe there were no symptoms for a long time until it strikes as a stroke. And then the person is rushed to a hospital, pays a lot of money, gets poor, and gets into a disability situation. So this is why we really need to change this game. This game is not working and we are not winning. So what do we need to do? So we prepared a paper some time back in the BMJ, which sort of list out what are the major elements. No surprises there. We need multidisciplinary teams. We need the right to prescribe medicines for trained mid-level non-physician care providers. Why? If 25 to 30% of the adult population is having hypertension and diabetes, we cannot insist that only medically qualified, clinically qualified people can only prescribe medication. So we need to have a step-down care that is made possible. No doubt that essential medicines are a significant issue here because the person is going to get treated for many decades, not for many weeks. And the health information system with unique identifiers, new models of care, and better mechanisms of referral. So this was behind we creating the HEARTS initiative, which has got technical programs for reducing risk factors such as the tobacco program with Empower, physical activity through the active package, salt reduction through the shake package, and replace for eliminating trans fatty acids. But my focus today is on the HEARTS technical package, which is for primary healthcare. So HEARTS stands for healthy lifestyle, counseling, evidence-based treatment protocol, access to essential medicines and technology, team-based care, and systems for monitoring. And we will see how this package is changing the game. So using this package, we can either start with hypertension as a starting point and then go through a standard process. We also have an app that is going to help with the process. And we have shown that scaling up effective treatment of hypertension is a pathfinder for UHC also. So hypertension can be a tracer. So if a primary healthcare system is not able to manage hypertension, then it says a lot about that system and what needs to change. On the other hand, once they know how to manage hypertension, which is so simple, one of the simplest NCDs, then they are actually on the right path towards UHC. Diabetes also is another entry point. In many parts of the world, like in the Pacific, diabetes is much more common and sort of socially appreciated as an NCD. So that could be the first point of contact for engaging the community into an NCD management. As all of you know that we have reached 100 years after the discovery of insulin, but even today in many parts of the world, children with type 1 diabetes don't see beyond their first decade of life. So WHO has started a global diabetes compact to reduce the risk of diabetes and to ensure that all people who are diagnosed with diabetes have access to good quality care. But again, as has been said before, there's a lot of clustering of risk factors as well as metabolic changes in a human being. And this always is compounded by depression. So that is an average middle-aged adult in most parts of the world. And that is why we think that a total cardiovascular disease risk approach is something that can be really used. So with the help of Emanuele and others at the Cambridge Cardiovascular Epidemiology Group, we have developed the WHO cardiovascular risk charts, which were updated to 21 global regions. Again, we have an app-based calculator with which you can calculate the cardiovascular risk and manage. They are all put under a package called Package of Essential NCD Interventions and can be downloaded in the App Store or Google Play. It is one thing to have process measures, but unless we know outcome measures, we are not going to be successful. So 6-monthly control of blood pressure can actually give an idea of how good the service delivery is. Or in the population, if you look at the hypertension cascades, you can see whether we are making a real impact on the ground. I would put it as a 360-degree care with person at the center. We have to identify and reduce the diagnosis gap. We have to improve with the continuous quality improvement to reduce the complications of non-communicable diseases. Innovation and self-care has become topical now, and we have to focus on impact. As I said, COVID-19 pandemic in many countries, we have seen telemedicine has been massively scaled up. Self-care has been brought in. Instead of giving medicines for 1 week or 2 weeks, medicines were given for 3 months, and new mechanisms for delivery of medicines have come up. So some of this has to be maintained post-COVID. So the game has to change into a system by which from the community you have a proactive primary health care that will reach out, identify people, manage them through standard protocols, do the laboratory testing, make sure there are medications, good counseling, and back to community, but supported by a good data collection platform. Now, does this all work? Yes. So here is an example from the Americas region of WHO, where 16 countries have taken up HEARTS, now with more than 700 health facilities implementing that. We also have a look at the global program that we are running. So we have reached more than 3 million people on protocol-based management. So what made the difference? The government agreed program where government is the main stakeholder with professional societies really helps. An evidence-based protocol, which is again endorsed by all parties, helps to sort of standardize treatment and reduce the pill load. Service delivery models based on the local situation. Capacity building was an important element, but I think a supportive supervision was found to be more useful than regular academic lectures on hypertension or diabetes. Monitoring was a challenge. I think one has to move towards electronic formats for cohort monitoring and unique identifiers. And in most places, the hypertension control improved. This is over a 2 to 3 year period, up to 30 to 40%. And this program is now continuing in many countries. So to summarize all that, from that initial picture that we have seen, we should go into a situation of proactive measurement of blood pressure, at least in the community, or use a non-lab-based CVD risk, which is quite possible. And then anybody with a slightly higher risk or a high BP can come into the health facility, get more blood parameters, and have a total cardiovascular risk assessed. They should then go for an integrated management and ensure that there is preventive care for cardiovascular disease, retinopathy screening, renal function, etc., with a financial protection so that if there is a referral to a high-end facility, that is covered, and then getting back to the community. This is possible. This is now happening in some parts of the world, but more of this has to happen. So if this game change has to happen, I'm sure we will be on target and we will make a difference. With that, let me close by quoting saying that there are no places worth, there are no shortcuts to any place worth going, which means that unless we put in systematic investment into primary care, appropriate to the local context, and have impacts which shows that the program is making a difference at the population level, NCDs are going to be a major challenge, especially compounded by COVID-19. So with that, let me thank the organizers and thank you very much.
Thank you so much, Cherian. That was again a marvelous talk, and we're so pleased that you were able to join us again this year, backed by popular demand due to our delegates' feedback from the session that you gave us. I know there are lots of questions, and we have overlapping questions that the delegates are posting in the Q&A session. So my proposal is that we will probably answer them as a team. because some of them will also cover what Mukesh is going to say later on. So if that's okay, Cherian, can we also ask yourself and Iveta to use the type answer function in the Q&A?
That's fine, Arpana. I will do that. Thank you very much.
Thank you so much. I'd like to introduce Margaret, who is with us from Edinburgh. Margaret, over to you.
Thank you very much indeed, Arpana, and thank you very much indeed to the organisers for asking me to present this morning. It is a real pleasure to be here. I'll just share my slides and make sure these are working. So I'm Margaret Douglas. I'm based at Edinburgh University. I'm also an honorary public health consultant with Public Health Scotland, where I chair the Scottish Health and Inequalities Impact Assessment Network, which has been running for 20 years this year. So the pandemic is very much not over. In fact, it's running out of control in the UK and many other countries at the moment. But in this presentation, I want to reflect briefly on some of the wider impacts of the pandemic so far, and also try to look forward to some of the longer term impacts that it might have on health, equity, and also sustainability. So I'll say a little bit about climate change, sustainability, and health, some of the ways that the pandemic has affected them, and try to persuade you that a health in all policies approach can help to address these in an integrated way. Most of my practice examples are from Scotland because that's where I've been working during the pandemic, but there are many other countries have seen very similar issues. So I think we should start with the very large direct burden of mortality and morbidity from the COVID-19 pandemic. As we've already heard today, more than 4 million people have lost their lives earlier than they otherwise would have as a result of COVID-19. And there's ample evidence that these deaths have not affected everyone equally. The graph shows data from England. It shows the age standardized rate of death attributed to COVID-19 by deprivation decile. And what it shows is that people in the most deprived areas, who are on the left of this chart, have been much more likely to die than those in less deprived areas on the right of this chart, with a gradient across deciles. And there are several reasons why people who are more disadvantaged are more likely to be exposed to the virus and also more likely to have severe disease, which I've summarised very briefly on the right-hand side of this slide. But I think the important thing to note is that these all reflect pre-existing social determinants of health. So even in the midst of trying to reduce transmission of a virus, it is important to recognise and address the underlying social determinants that make some people at higher risk. And the impacts of the pandemic on social determinants and on health inequalities go well beyond these direct deaths. So these are some of the pathways through which the pandemic has affected social determinants and health. And you can see they include economic effects, effects on employment, effects on mental health due to social isolation, family relationships, disruption to services, loss of education, many, many different impacts. The infographic on the right of this slide is from a very rapid health impact assessment that we did over a year ago to try to identify the likely wider impacts of social distancing measures. And it shows a very complex set of interconnected pathways through which all of the effects of COVID-19 affect intermediate determinants and therefore affect health. I'd like to acknowledge my colleagues listed on this slide who were all involved in this very rapid health impact assessment. But looking at the pathways listed on this slide, it's clear that people who already have poorer health, people in more deprived communities, are more likely to suffer from the adverse effects. And I'm not going to talk any more about these pathways during this presentation, but we have been tracking them. And it's very clear that that is exactly what has happened. So almost all of the impacts that we predicted over a year ago now have happened in the UK at least, and they have worsened health inequalities. So overall, again, I think this highlights the need to continue to work on the underlying social determinants that have made some people at higher risk from COVID-19 and have themselves been exacerbated by the pandemic. So the pandemic has been and very much still is a health emergency, and governments have very rightly responded with measures that often would have seemed unthinkable pre-pandemic. Global climate change is a slower emergency, but likely to have even more severe effects and requires equally radical actions now to reduce greenhouse gas emissions. I'm not a climate scientist, and I'm not going to show any graphs this morning demonstrating rising global temperatures, but the extreme weather events that we've seen in recent weeks, particularly in North America and the flooding in Europe, I think illustrate some of what we will expect to see a lot more of unless we take radical action now. These are some of the health impacts of climate change that we are actually already seeing. So there are the direct weather effects that I've just talked about, effects of heat stress, as we've seen in North America, storms and flooding. And as well as the adverse effects on physical health and injuries, these have long-term effects on mental health. And then there's effects on environmental systems, causing increases in vector-borne, foodborne and waterborne disease, allergens, poor air quality. And then there are less direct, wider effects, such as food and water insecurity, displacement and forced migration of people causing trauma, flows of people with new health and service needs, likely social disruption, likely violence. All of these are negative effects, but the impacts of the policy responses to all of these and to climate change could be either positive or negative, depending on the choices that we make. WHO estimates that there will be 250,000 additional deaths every year between 2030 and 2050 due to the effects of climate change. And again, many of the populations most at risk are the same people who have experienced the most adverse effects of the pandemic. This is a global public health issue. And consideration of sustainability, of course, is broader than climate action, important though it is. These are the Sustainable Development Goals, which I know are a theme of this conference. Number 3 is about good health and well-being, but all of these goals are determinants of health. So what that means is that working towards the Sustainable Development Goals in an equitable manner should improve health, and improving health determinants is a contribution towards the Sustainable Development Goals. So what does the pandemic mean for sustainability? It has affected all of us in many ways and is likely to have longer term effects on how we live that have implications for health, equity and sustainability. I'm going to discuss just a few of these. I can only really scratch the surface, but I'm going to discuss a few of these changes that we have seen in the next few slides. So firstly, there have been changes in where we work. This slide presents data from the UK Annual Population Survey, showing the proportion of workers in the UK who report that they ever work from home. In 2020, this increased and over a third of people said they worked from home at least some of the time. And other surveys suggested a large proportion of this group wants to continue working from home for at least part of the week. Working from home could affect health in different, in fact, even opposite ways. This slide summarises some of these impacts and it draws on the 2 documents that are shown. The purple one is a rapid scoping exercise that we carried out in Scotland, and the blue one is a much more detailed review, including stakeholder involvement and interviews from the Wales Health Impact Assessment Support Unit, but they both found very similar impacts. So not having to commute might mean that people get less incidental physical activity and less incidental social contact, but it does save time that can be used for other activities that could be good or bad for health. We know that many people feel isolated working from home, whereas others find being in the workplace stressful, and some people have found that working from home improves their mental well-being. There could be impacts on family relationships when everyone is cooped up at home, trying to work in a small space with potential safeguarding issues. There are impacts on work-life balance, on productivity, and also on health-related behaviours, which could be either positive or negative. And so the overall balance will differ for different people. There could also be impacts on local communities. We've seen concern about the impacts of town centre or city centres when people are not travelling into city centre workplaces anymore, but there could be benefits for local centres if people are using local businesses more, and they might be available to support their neighbours more. And all of these also have equity implications. For some disabled people, being able to work from home has actually been transformative, allowing adaptations that they really can't access in the workplace. But of course, not everybody can work from home. And you saw in that survey that 2/3 of people were still not working from home, even during the pandemic. And even among those who can work from home, there are variations in whether they have suitable space. They may face the costs of having to heat their homes and to purchase equipment, and it exacerbates existing problems of overcrowding. And it may actually bring new inequalities, as there's evidence that people who exclusively work from home are less likely to be promoted. Working from home also has impacts on greenhouse gas emissions, which again may be positive or negative. Climate Exchange has been modelling these on behalf of Transport Scotland. So they found that emissions associated with commuting and with heating office space are reduced, but home energy use is increased. So the net population impact is small. And the climate impacts of an individual changing to work from home vary depending on how they previously commuted, the type of home they have, and the type of home heating they have. So if we see a pattern of people moving to larger houses out of town with poorer public and active transport access, but then perhaps driving into the office once or twice a week, that could increase overall climate emissions. So a second change we have seen is in how, and indeed if, people move around. During the pandemic, I've been chairing a partnership group called the Social and System Recovery Transport Group that is hosted by Public Health Scotland. And we published the document that's shown in the slide last autumn with the transport trends during the pandemic, their health implications, and some recommendations. We're now doing a health impact assessment of road reallocation. So this slide shows trends in journeys by car, bus and train in Scotland from April 2020 to June 21 as a percentage of journeys by each mode in 2019. So it shows there was a steep drop in journeys by car, which is in blue, and public transport, which is in red and orange, near the start of the pandemic. But car journeys then increased to a greater extent than public transport, so that by the start of June, car journeys were very close to 2019 levels, even though many people are still working from home and many venues are still closed. In surveys, 70% of people say they're concerned about contracting or spreading the virus while using public transport, and that is regardless of their vaccination status. And 40% of people say they'll continue to avoid public transport even when all of the restrictions are lifted. So this could suggest that car travel might rise well above 2019 levels, and some public transport services could become unviable. Changes in transport mode, not surprisingly, have big impacts on emissions because transport is the most emitting sector in the UK, accounting for 27% of domestic greenhouse gas emissions. The pie diagram on the right of this chart includes both domestic and international transport emissions, and it shows that cars account for the biggest share, even taking international emissions into account. Transport also, of course, impacts on several health determinants that affect not only the individual traveller, but also the wider community. And we've already heard earlier from Iveta about the benefit to air quality if more people choose to walk or cycle. But in fact, there are many other positive benefits from active travel, including increased physical activity, social connections, exposure to green space, and footfall for local businesses and services. On the other hand, cars have mostly negative impacts, particularly for the wider community, and these include collisions, pollution, severance, loss of public space, and inactivity. Public transport has both positive and negative impacts, but it's really important for transport equity because it enables access for people who can't access a car. So if the trend of increasing car use continues and public transport becomes less viable, this would have multiple adverse effects on health and equity. So finally, the pandemic has affected how we use public open spaces and green space. As well as the transport group, I'm also a member of a similar partnership group working on environments and spaces. This slide shows data from colleagues in the University of Glasgow who have been tracking green space use using repeat online UK-wide surveys. They were carried out in May 2020 during the peak of the restrictions, November last year, and then April of this year. So whereas less than half of people had visited a local park or green space in the previous 4 weeks in May of last year, by November and April, about 2/3 had, which is similar to previous surveys. So this suggests that the restrictions had more impact than weather or seasonality, which is very important in the UK. But even by April of this year, some people were still reporting that they felt green spaces were too busy or they were unable to socially distance, and that was a very important barrier to using them. There are significant inequalities in use of green space, particularly by socioeconomic status. The graph shows the proportion of people who visited public green space in the past 4 weeks for each of those 3 time periods. The dark green is high socioeconomic status and the light green is low socioeconomic status. And you can see that in each of these periods, there was a significant difference, with high socioeconomic status people much more likely to make use of green space. So just the availability of green space, but also green space use, has clear benefits for health, sustainability and equity, and I've summarised them on this slide. So green space, particularly urban green space, contributes to climate change mitigation and adaptation and biodiversity, and it has important benefits for both physical and mental health, particularly for vulnerable populations. During the pandemic, there has been concern about the risk of transmission in crowded public green spaces, albeit the risk is much lower than in crowded indoor places. But the concerns about crowds in public spaces need to be balanced against all of these benefits. So this slide shows on the right-hand side policy guidance on safer public spaces for Scotland, and guidance on the left on management of parks and green spaces during the pandemic. And for both of these, our Social and System Recovery Environments and Spaces group held a workshop with some public health and other stakeholders to review the draft guidance to consider how it would affect a series of different populations and a range of different determinants. And these scoping exercises were written up in the purple documents that are shown here. So they were very quick and dirty workshops, but they were structured and systematic and allowed us to feed these wider considerations into these policies, even given very tight decision-making timescales that we've had in the pandemic. And I think this is a good example of a kind of exercise which we call a health in all policies approach, which can ensure that broader aspects of health and equity and sustainability can be considered in an integrated way in policymaking. So this is a WHO definition of health in all policies. It means systematically integrating consideration of health into all public policies, both to enhance positive effects on health and also to prevent health harms. And today I've talked about just a few of the links between health, equity and sustainability, and the overlap between these and between health determinants and the Sustainable Development Goals. But this means that health in all policies can be a way to work towards the Sustainable Development Goals. As we move into pandemic recovery, we need policies that address the issues that I've talked about here and many more, without inadvertently creating new inequalities or having other unintended adverse effects. And I think that health in all policies is an important role for public health to play in this. Health in all policies involves collaboration with partners, particularly policymakers, and it also involves advocacy for policy change. But it's different from most of the collaborative work or public health campaigning that we do, which usually addresses single health issues. It involves working with policymakers in a defined sector, seeking to understand their opportunities and constraints, and working with them to consider how proposed policies might affect the whole range of populations and a whole range of determinants. There are very well-established approaches like health impact assessment to do this in practice. I believe that at a time we're facing the multiple challenges arising from the pandemic, rising inequalities worldwide, and climate change, which are all linked, it's really important for public health to engage in this kind of integrated approach. So in conclusion, I've talked about just a few of the strong links between sustainability, health and equity. There are many other links between sustainability and health during the pandemic that I could have talked about. There are multiple likely long-term effects of the pandemic on health, equity and sustainability. And I think it's important to consider these in forming public policies in an integrated way. And therefore, I think that health in all policies is an important role for public health to play in pandemic recovery. Thank you very much indeed for listening. That is my email address, and that is the web address of the Scottish Health and Inequalities Impact Assessment Network, where you can find our resources on health impact assessment and health in all policies, including the purple documents that I've shown today. Thank you.
Thank you so much, Margaret. That was really helpful in terms of some of the work that we're doing as well, and we will definitely be checking out your website. There's quite a number of questions for you, so I'm just filtering.
Oh, I've just lost you, Arpana.
Hello?
Hello. Oh, I can hear you again.
Oh, brilliant. So your talk has stimulated many questions. So I'm filtering them and they are in the answer tab. So we would very much appreciate your answers in that answered tab, and I'm doing it for the other questions as well. But Margaret, thank you so much for presenting your fabulous work, and we look forward to interacting with you going forwards as well. Thank you, Margaret.
Thank you very much.
I'd like to now introduce our next speaker, who is a long-standing friend of the festival from probably one of the first ones, and is one of our emeritus professors as well. Mukesh, welcome, and I'll give you the floor. Thank you.
Thank you, Arpana. I'm glad to be participating in this festival again. I have no slides, so I'm afraid your speakers will have to just watch me and take whatever inspiration they can from that. I'm going to talk about the malign influence of COVID-19 on global health and on health in general. And while there has been much technical commentary on the topic, I think there are some long-term moral consequences that I think we need to worry about. Now, when catastrophe strikes, especially one that upends our lives on a massive scale, it's normal to seek sense from the sudden shock. We need consolation by finding some special, perhaps spiritual meaning in the damage and disruption. We also want hope for something really good to come out of a terrible disaster. And along the way, we strengthen ourselves by blaming someone else for our troubles, be it a failing leader, a failing institution, or a foreign country. We also rationalize our fears and forebodings by hypothesizing a clever chain of causality to explain everything. But just in case, we also pacify the gods of our misfortunes by promising to live better, to do better. We sincerely resolve to invest more in prevention, or in science, or in green growth, or in correcting inequalities, or whatever happens to fit a particular scenario according to whichever crisis has unnerved us at a moment in time. All of this is then captured in acres of commentary from which mountains of lessons are extracted. This is true of all mega crises from whatever cause. The coronavirus pandemic has also followed the same course. If you punch in the phrase lessons from COVID-19 into Google, it throws up some 440 million results and counting. The extensive narrative around the pandemic is actually consolidating around some key themes. The first theme is self-congratulatory. It marvels at the speed with which the coronavirus was identified, sequenced, and vaccines invented. Also, how quickly treatments have improved. It's all about how clever we are, how innovative, how ingenious, and soon several scientists will be disturbed in the middle of the night. They'll be woken up to hear about their Nobel Prizes. The second theme is heroic. It showcases desperately sick patients gasping for breath. It applauds health workers battling against the odds. Also social workers caring for the most vulnerable. And humanitarians bringing help and comfort to isolated or forgotten people. The kindness business has thrived. We hope that for some of them at least, they will get medals and certificates. The third theme is of astonishment. This is around how governments and international financial institutions overturn orthodoxy to find or print trillions of dollars to prop up businesses and expand social safety nets. as well as the many other adaptations that companies, communities, families, and individuals made to carry on as best as they can, be it homeschooling or Zoom connecting. It seems that people were astonished by their own adaptive capacities and resourcefulness, including their willingness to tolerate lockdowns and other extraordinary limitations to basic freedoms. The fourth theme is exhortatory. These are appeals to the better angels of our nature, because we are in it together. So we are urged to show solidarity, to be altruistic. But as that doesn't go down really well on a large enough scale, this is mixed with self-interest. To wear masks to save others, but it also saves you. To share vaccine stocks equitably, because no one is safe until all are safe. Pharma are exhorted to share their intellectual know-how so that others can make the vaccines themselves. There's also a growing stream of exhortations around future improvements and challenges to the way we live or organize our health and social systems or our ecosystems so as to avoid future disasters or to deal better with them. The fifth theme is of lamentation. It mourns the many tragic losses of lives and livelihoods. Of course, but above all, it also regrets the passing of an old normal, which will never be recovered. And now, if you notice more recently, there is now a new lamentation about the epidemic of the cave syndrome, which is the fear of people who don't want to actually go out. They've so much appreciated being in lockdown that they're actually afraid to go out, the cave syndrome. So we're now lamenting that as well. The sixth theme is retroscopic. There is a thriving industry around becoming wise after the event. There are several strands to this theme. The most significant is the launching of investigations and inquiries into the origins, causes, and mishandlings of the pandemic. This helps to diffuse criticism of the present by turning to the past that has already safely gone by. Often there is a comparative aspect that looks at the relative performances of cultures, governance systems, and institutions. As there is always someone worse than you, it helps to divert blame. Another way to divert us from contentious realities is to invoke distal influences that are so broadly cast as to render real-time decision-making and decision-makers virtually unaccountable. So, for example, we can blame uncontrolled environmental change for boosting zoonotic transmissions. We can blame crowded urbanization for magnifying vulnerabilities, Chinese communism for the original unleashing of the coronavirus, cheap world travel for its rapid spread, rampant capitalism for the pandemic's obscenely unequal impacts. We can blame the food industry for making us fat and vulnerable to the virus's complications. We can blame social media for spreading mischief and misinformation. We can grumble at unchecked globalization for hollowing out nations who can't produce their own paracetamol or their PPE. Profiteering pharma for not making enough vaccines for everyone, and geopolitics for ineffective multilateral cooperation or institutions. And into this, and based on your agenda, you can inject other narratives such as Black Lives Matter, whether or not the Olympics should happen, and culture wars of many different types, and even probably football. The seventh and final theme is perspective. There is prolific punditry around envisioning the post-pandemic world. Most projections envisage digital takeover of most aspects of life, even as large elements of distancing continue, if only in our hearts and minds. The emerging world may be a somewhat colder, more robotic place. It may also be much more fearful and cautious as we await the next pandemic or climate disaster. Thus, one enduring legacy of the coronavirus may be a permanently changed perception of risk. Public policies and private practice will default to more risk-averse attitudes. Could the precaution principle take all the joy out of living? Now, clouded by so many perspectives, it's difficult to tell if the COVID glass is half full or half empty. And meanwhile, there is a more fundamental concern that I have. This is to do with core values around health itself. Now, since millennia and across cultures, health has been seen as an inherent good, i.e. the pursuit of good health is seen as desirable in of itself. This has got codified as a right to health in the 1948 Universal Declaration of Human Rights and subsequent international laws and covenants. But at the same time, we've also learned that diseases can't be stopped at the front door of your house or at the borders of your country. Therefore, to ensure your own safety requires securing the safety of others so that they don't threaten you by infecting you. This leads to the noble notion of health for all, be they your neighbor or a distant stranger. This has, over the course of repeated telling, achieved holy status, not least because it appeals to your own self-image of decency. But such apparent benevolence is helped along by the happy thought that while you do good to others, you're also doing good to yourself. Therefore, the specialty of public health and then global health, which often projects itself as a moral mission to do the greatest good for the greatest number of people, is actually in constant tension between the instincts of selflessness and self-interestedness. That is why solidarity messaging around COVID-19 often appears to fall in a semi-deaf no man's land. Historically, when the pursuit of health was largely an individual endeavor, or at best an uncertain partnership with your healer and your God, selflessness predominated because this was seen as a spiritual vaccine. But health for all could only be pursued through institutionalization, with, of course, plans, strategies, objectives, and metrics. Thus emerged the modern health organizational setup, whether under health ministries in the public sector or as corporate business. In either case, an institution is logically geared towards self-interestedness, i.e. serving rationally its set mission, even if the institution is composed of selfless individuals. Thus, it is that we see so much of COVID-19 nationalism in relation to border restrictions and vaccine hoarding. Meanwhile, as health becomes an institutionalized business, nations are being encouraged by the global multilateral enterprise to compete to achieve first the Millennium Development Goals and now the Sustainable Development Goals. These paradigms see health as an outcome, but even more as an input for the project to create stronger nations. That necessitated the further instrumentalization of health. For example, health expenditure was required to demonstrate a return in terms of more productive societies. Therefore, health was no longer just an intrinsic good to be achieved for its own sake, but an input to a process that generates wider economic benefits. For example, better maternal and child health services mean healthier babies. Obviously, this is an intrinsic good, but these babies grow up to become strong workers, and this is the instrumentalized good. So ultimately, healthy and strong workers make strong nations. It is then but a short conceptual leap, or rather a step, to visualize health as a strategic security concern that is legitimate fodder for geopolitical competition and rivalry. That also implies that when a disease breaks out and spreads widely, the country that recovers faster has an advantage compared to the others. Recognizing that explains why the global COVID-19 response has been marked by so much contention and acrimony. The coronavirus has driven us apart and not brought us together because the underlying health moral base has been instrumentalized and securitized. COVID did not cause this. It has simply accentuated the trajectory we were already embarked upon. On this analysis, what does a post-COVID future hold in global health? Well, the positive aspect of a securitized health field is that it will stimulate more investment in medical science, in discoveries, and in medical inventions, including the fields of artificial intelligence, health surveillance, and big data collection and analytics. The negative aspect is that exactly the same things are happening and will happen in the same using the same security sector technologies that are seeing the massive investments to make wars more effective and more efficient. So as the health sector gets more effective and efficient, so does the war-making sector, using the same technologies. Either good or bad, our health is now a matter of national security. And as citizens, all of us are conscripted soldiers. So be happy, be strong, just in case you're needed to fight others. Thank you.
Yes, and as ever, a very thought-provoking Greg has said that we can carry on until 1:15. And so what I propose is that we will do some of the questions to the panelists at that time, and I hope our attendees can stay with us. I'd like to welcome Lynette, and very excited to hear your talk. Thank you so much for coming to the festival, and looking forward to your presentation. Thank you.
Thank you, Professor Aparna Verma, for introducing me, and thank you, Greg, for the kind invitation to join this year's International Festival of Public Health. I'm delighted to have the opportunity to present to you today a brief introduction on infodemic management on behalf of the WHO Information Network for Epidemics. In this talk, I'll firstly explain what an infodemic is and how it can cause public health problems, and secondly, what we are and can do about it. This works. Oh, yes. And silly me, I forgot to introduce myself. I'm the technical officer of infodemic management at the World Health Organization headquarters here in Geneva, Switzerland, and I work as part of the team helping to grow infodemic management as a discipline, as well as the tools and approaches for better health preparedness and emergency response. Apologies for the backward introduction. So firstly, what is an infodemic? You might remember over a year ago, the WHO's Director General Tedros raised the alarm about the twin challenges of fighting an epidemic as well as an infodemic. An infodemic goes beyond an overabundance of information. We see a surge in information and rumors, including misinformation. In times of emergencies and uncertainty, when faced with this infodemic, it makes it even harder for people to find reliable information that could help them make informed decisions to enact healthy behaviors to protect their health and their communities. So what is misinformation? Misinformation is inaccurate information, which includes kernels of truth and is often shared by people who intend to do no harm or mislead. Disinformation, on the other hand, is false or inaccurate information shared with the intention to mislead or do harm. The main difference between misinformation and disinformation is motivation or intent. An infodemic can cause serious harm, as the confusion can lead people to ignore public health measures and take risks. You may recall hearing the tragic reports during the past year of people being poisoned by drinking methanol or improperly using cleaning products. But there are other consequences of an infodemic. It exacerbates mistrust in science, health authorities, and in public health measures. So how do we get into the infodemic? Some people think that the infodemic is only a problem of online misinformation. Experience has shown that certain events can affect the way the information environment, online and offline, can affect the information environment online and offline, making it hard for those trying to tackle misinformation to do so effectively. Think election times, natural disasters, and of course the COVID-19 pandemic. But what has made the COVID-19 infodemic such an unprecedented challenge is the fact that we're experiencing an epidemic in a digitized global society. So we live in a digital world, and the infodemic crosses borders and digital and physical spaces. Really, the information ecosystem has changed so that there is no distinction between the online and offline world these days. So in short, our communication ecosystem looks very different from what it did before, and advances in digital media are making it easier than before to rapidly share unverified content. And as such, rumors can travel across borders quickly. It's a global phenomenon. And to reduce its harmful effect on our ability to control the pandemic, we need everyone involved. We need all parts of society to get involved, and we need to manage the infodemic across multiple levels and communities from the global and local level. So we need to better manage the infodemic to save lives during health emergencies, to build and maintain trust in health authorities and health measures, to reduce susceptibility to misinformation, and to ensure universal access to credible health information so that everyone can make more informed decisions about how to protect themselves and each other. So how do we do this? Well, we need to continue to build the discipline of infodemic management. The WHO has addressed infodemic management through developing a framework with 50 global actions, developing a public health research agenda for managing infodemics to accelerate investment in the science and innovation for an evidence-based approach, building new partnerships and a toolbox for countries, rolling out a competency framework for infodemic management, and training a whole new generation of infodemic managers to effectively use these tools. And just this year, 5 journals came together with a call for papers to tackle aspects of the research agenda, and special issues will be coming out throughout the year. 2 of them have already come out with papers. So I guess to manage the infodemic, we need an evidence-based framework like that of epidemiologists for advancing the science. The infodemic management needs to be mainstreamed into epidemiological preparedness and response plans, because flattening the infodemic curve will help us to flatten the epidemic curve. And as such, we want to integrate infodemic management into our health, security, and preparedness plans. And we also need to identify the information gaps and data voids and fill them before they're filled with viral misinformation. And we need to ensure strong feedback loops so that we can better track changing concerns in community. So let me walk you through some of the things that the WHO has been doing in developing out the infodemic management area. So firstly, in early April last year, the WHO Information Network for Epidemics, EpiWin for short, held a global consultation on managing the infodemic. The aim of the consultation was to crowdsource ideas for managing the infodemic from an interdisciplinary group of experts to feed into a draft infodemic response framework. Through an online interactive forum, close to 600 ideas were submitted with participants over 2 days. The outcome of the EpiWin global online consultation, 50 proposed actions for a framework for managing infodemics in health emergencies. So the framework provides guidance for governments and public health institutions to take action in 5 key areas that emerge from the consultations. So you can see those on the slide. So number 1, identifying evidence. Number 2, simplifying knowledge. Number 3, amplifying action. 4, quantifying impact. And 5, improving coordination and governance. So the WHO intends to continue to refine this framework based on the experience of the COVID-19 infodemic response, lessons of other disease outbreaks to support preparedness and response in the future, and inform risk mitigation. Sorry. So I encourage you to download the research agenda here and look at how to contribute to it, because there are lots of questions for us to answer, such as how infodemics and online influences are affecting offline behavior, and which interventions will be more effective to manage the infodemic. We all have a stake in infodemic management. It isn't just the responsibility of the WHO or health authorities, but also for academics, researchers, the media, and civil society. So the research agenda comprises of 5 streams of thinking, 65 research questions developed and prioritized so that the practice of infodemic management has a structure, evidence-based methodology, and room to evolve as a discipline. Accordingly, it serves as a playbook for conducting relevant public health research and builds direct focus and investment into the emerging field. It provides guidance to invest in research and innovations so that we have better interventions and tools to understand, measure, and respond to infodemics, and ultimately steer people towards timely, accessible, and understandable health information that can help them make good or better health choices. So one thing is clear, we all have a role to play in operationalizing the research framework. So worth checking out is this exciting initiative of the Africa Infodemic Response Alliance, apologies, so IRA for short, a WHO-hosted network that coordinates actions and pools resources to manage the infodemic by addressing information gaps and tackling misinformation around the COVID-19 pandemic and other health emergencies in Africa. We all know that false claims can spread faster than COVID-19 itself because they're simple, visual, and tap into our emotions. And that's why Viral Facts Africa launched on March 30. It connects health experts, fact checkers, and communicators to inoculate people against harmful misinformation, essentially working together to make good information go viral. So to date, in terms of the training, I'm delighted to share that the WHO has just recently hosted its second Global Infodemic Management Manager training. So it's now hosted 2. So the first one in November 2020 and just this year in June 2021. We have trained over 500 participants from 119 countries and counting. But the global infodemic management response, as you have heard now, requires more trained infodemic managers to support infodemic management efforts across the globe while promoting resilience of individuals and communities to the infodemic, including mis and disinformation. So watch out for a call for applicants for the 3rd ever Global Infodemic Management Training planned for later this year. Subscribe now to the Infodemic Management Newsflash to join our growing global community of practice and get access to alerts about new resources, funding opportunities, new research, and lots more. Subscribe via the bit.ly link that is shown on the slide. I'll make sure to share the link in the chat after I present. And I guess we've reached the final official slide of my presentation deck. So my final call for action is a request for everyone joining us today to have a read and sign our call for action to be an infodemic manager in your daily life. We have more than 500 signatories and counting from diverse organizations. So join the movement as a champion for truth and global health. Thank you.
Thank you, Lynette. Again, I think there's a lot of questions from the chat, and it's going to be really great if you are also able to stay with us for a bit longer. But thank you so much for that work, and it's really helpful in determining how we go forward. And so I'd like to introduce our next speaker, Will, who's been a friend of the festival, also probably from the beginning, but he's very kindly agreed to present the Marko Petrovic Memorial Lecture, and we're so pleased to welcome you. Thank you, Will.
Thank you very much, Aparna, and thank you for the invitation and for all of those who have joined us. So just as a brief introduction, my name is Will Welfare. I'm a public health physician with a particular interest in health protection. And I'm currently within the national team in Public Health England, but also an honorary clinical senior lecturer at the University of Manchester. Marko Petrovic was a consultant in communicable disease control within Greater Manchester, and I had the honour and pleasure of being a colleague and friend. One of Marko's strong interests was tuberculosis control, and within that he was involved in the very early use of TB genotyping and then subsequently sequencing in public health. He was also a passionate communicator and very keen to share what he knew and understood about TB with others. So with those two interests in communication and genotyping sequencing, it felt appropriate in 2021 to briefly talk about COVID-19 variants, both the use of genotyping sequencing, but also highlighting what is publicly available and some of the shifts we've made to make sure things are much more publicly accessible. So just to start at the beginning with what are variants, and essentially every time the virus replicates, there's a possibility of there being minor errors in that, minor imperfections in the copies made. And over time, those changes can build up. Most of the time, the changes are so small that they have very little impact, but every so often, there's a mutation that delivers a benefit to that particular virus, and therefore that particular version or variant of the virus may well spread and become an increased issue in public health terms. And this is just an example of that. This is the beta variant, and this is a phylogenetic tree taken from GISAID, which is the global repository of sequences, and each of these colored dots is a different sequence mapped over time, so you can see the emerging diversity of this one particular variant, as well as the huge amount of information that is available to us on this. And you can see similar things in each of the other variants with a huge amount of detail. Within the UK, we talk about variants under investigations and variants of concern. And there's a separation in those terms in terms of the amount we know about it. So variant under investigation has got changes which are potentially concerning and evidence of some spread, either in the UK or internationally. While a variant of concern has those demonstrated significant changes in characteristics, resulting in a significant change, whether that's transmissibility, severity, or infectivity. And the language here is changed. WHO brought in some new nomenclature based on the Greek alphabet, which gives us a universal way of referring to these. There is also the lineages which are used, and the UK also has a designation which is based on the year and month of designation. The UK nomenclature is continuing to be used because there are some variants that we are tracking that don't currently have WHO Greek letter assigned to it. So the language around here is improving, but is still fairly complicated. One thing I would refer to is that we are trying very hard not to use geographical designations for these, and actually rather than referring to the country of first detection, trying to use a more neutral language. So we look at what we do in terms of detect, analyze, and respond. And we've fortunate to have a significant sequencing capacity in the UK, and that allows us to do daily scanning of all the sequencing we get coming through to determine what variants we're seeing. We also need to then take that through to look at variants that we've detected to make sure we've got a good risk assessment and further investigations around those. But not forgetting, key is actually what we do with this information and sharing those out with our regional and local public health teams to make sure that we've got that enhanced public health management of particular variants, individual cases and outbreaks, but also to help us to understand what's happening within the UK and internationally, and that guides the wider control measures, including some of the policy decisions. So in terms of detection, we're using a combination of whole genome sequencing, which is the full characterization of the variant. It's, as it says, literally sequencing the whole genome. So we see a huge amount of detail, but it does have therefore a slightly longer turnaround time of usually between 7 and 10 days. We also are increasingly using rapid genotyping, which is an assay that can identify particular targets and use those particular targets to make a early provisional identification of a known variant of concern. Rapid genotyping is considerably quicker than sequencing, getting results within 24 to 48 hours after a PCR positive, but it will only allow the identification of known variants, and there's a limited number of targets we can include within the assay, so limited number of variants we can detect through genotyping. UK has got high sequencing capacity in global terms, and that means that we can maintain good coverage with our sequencing. However, it's not possible to achieve 100% because not all samples are actually sequenceable, and that's really relates to the quality of the sample and the number of virus copies within it. So some samples we can't analyze, unfortunately. So we track the variants, and this is a chart taken from one of our routine reports, and all of the charts in this slide set are in public domain, published in our routine reports. But this just illustrates the prevalence of different variants within England, and really the emergence of Delta to become the dominant variant, and other variants remaining at very low levels comparatively. So we continue to track this to both understand the dominant variant, but also to understand what other variants we are seeing and what actions are required. So that's the detection side of things. We also have a routine system for risk assessing these variants, and this is the framework that we're currently using, looking at different levels of risk, but also confidence grading around the evidence available. And in particular, we focus on transmissibility, infection severity, impact, immunity after natural infection, and vaccines, and the possibility of vaccine escape. So this gives us a standard framework to look at a range of variants and understand the available evidence. So this is, again, the most recent published version of that analysis for Delta variant, which is currently dominant within the UK, and demonstrating that, and this provides a, is really a summary of what we know about it in terms of increased transmissibility compared to the wild type. That's the first wave virus. Greater severity when compared to alpha, and some epidemiological laboratory evidence of reduced vaccine effectiveness, particularly against symptomatic infection, although vaccine effectiveness against hospitalization is maintained. And then bring that together into our overall assessment, which helps guide both public health and policy responses. Mentioned vaccine effectiveness, and I thought I'd just pull that out as that's one of the key issues at the moment within the UK. And one of the things to emphasize here is people often talk about vaccine effectiveness, but one of the key questions is the effective against what? What are you actually looking at it to do? There's a range of possible outcomes you can consider vaccine effectiveness, and commonly symptomatic disease is used, and hospitalization and death, but you can also consider infection and transmission as well. So this is pooled data for 1 and 2 dose vaccines, and seeing that second doses are really important in terms of effectiveness against symptomatic disease for both alpha and delta, and that vaccine effectiveness against hospitalization is maintained for delta at very high levels. This giving a central estimate of 96% effectiveness after 2 doses. And again, the links to where we published it in our technical briefing, as well as the source paper, which was published as a preprint. One of the things our risk assessments do is drive our onwards investigations to try and understand more about these individual variants and trying to build it up from the available information. And this is often limited. And as a variant first emerges, there is limited information, and we have to provide a risk assessment based on that, and then refine it as we get more and more information. And some of these investigations necessarily do take some time. So if you want to look at laboratory models to understand something about transmissibility, a number of those actually rely on having virus cultured to run it and do things like neutralization assays against different sera containing antibodies, either from natural infection or vaccination. But actually growing a virus up in a laboratory does take time. We can also do a series of observational studies looking at household and secondary attack rates, as well as going on to look at hospitalization and mortality in terms of severity. But again, we do have to have an observational period, and to make reliable estimates, you're going to have significant significant or adequate numbers here. So again, the information will emerge over time, and there are some limitations to how rapidly we can provide detailed risk assessments. I've already mentioned vaccine effectiveness, and included in the slide is an extract against some of those different outcomes, with the caveat that those data relate to when alpha variant was dominant compared to the current delta. And this is the bit that I'm most involved in, which is the response to different variants and building on our existing response, making sure we've got really good test, trace and isolation in place, as well as work to do detailed case finding, often taking an approach similar to many other infectious diseases, and particularly TB, starting testing in the highest risk groups and then moving out from there, trying to find cases of it, either to identify a source or identify those who've acquired that variant from the initial cases. And the size of those varies. We've done both very targeted testing, but also at community level as well. There may be some other wider measures considered and policy implications, and we've seen some of that in terms of travel policy. Just to flag that we publish weekly variants detected, both on the website and as a couple of routine reports with a technical briefing and some underlying data reports as well. And we update our vaccine effectiveness estimates weekly. And this is just trying to pull out some of the detail. This again is back to beta variant, but reporting on its occurrence over the regional distribution, but also by age and sex. So it's fairly standard epidemiological analyses which are routinely updated and published. We tend to keep on talking about new variants. It's important to remember that actually we also see variants disappearing. So these are some examples of provisionally extinct variants which haven't been detected for at least 12 weeks within the UK. And so the ones we're tracking constantly changes, these will be kept in monitoring, but we certainly haven't detected them in recent weeks. I just wanted to end on this, just to highlight the huge amount of information out there on variants, and our attempts to make sure that we continue to share what we know and make sure it's available in an accessible format. So both within Public Health England's website, which is on the government website, but also GISAID, which is the international consortium, which acts as a repository for all of these sequences, and the a UK sequencing consortium, COG UK. Thank you. Aparna.
Thank you, Will. That was really helpful in terms of navigating the phenomenal work that PHE and yourself and colleagues are doing with keeping all of this information up to date. And our thanks for delivering the Marko Memorial Lecture. He's always in our thoughts. So thank you for that, Will. Please, can I ask the panelists to unmute themselves and put their cameras on? We've got questions not only from the Q&A, and thank you for answering some of them, but also from our other feeds. So I'm going to just start off with this sort of issue that a number of people have highlighted between the balance of how we deal with non-communicable and communicable disease funding post-pandemic, and your thoughts around what we can do as a public health body, as public health professionals, both from your personal and your professional side of things. I'd like to start with Iveta.
I unmuted. Okay, so thank you very much, Arpana. I think I have answered already this question in the chat. So exactly, as being the president of the YUFA section on chronic diseases for 12 years, this was exactly one of my concerns in the beginning of the pandemic, because I saw that people with chronic conditions were somehow neglected. Nobody was talking about them, despite the importance of the problem. And only after some time, or actually, let me just continue in this thought. So it led to really a lot of complications, I would say, with regard to prevention and screening of the cancer, and also delays in care. So many people actually died just because of these things, or their health status was worsened. After a few months, the people with chronic condition came more into the spotlight, but still, as I mentioned, I still have some concerns whether the funding will not be directed disproportionately to COVID-19 topics. And please understand me correctly, I'm not saying that COVID-19 is not important, but I would say that some of the decisions are politically driven or business driven. And I would say that we definitely, as public health experts, need to pay attention also to these issues and talk about the evidences, the evidence-based, as I said in the beginning, that chronic conditions for me are still the major public health issue. And actually even COVID-19 showed that how they are interlinked, that people with chronic conditions were more susceptible to have more severe cases or more infectious. So I would say we as public health experts need to be really very vocal regarding this and kind of like fight also the politics and the business and the economics, which is not always easy, let's be honest.
Thank you, Iveta. Mukesh, would you like to go next?
Sure. I think I would like to say that this question really poses a much bigger question, which is a rationality of health financing in general. I think, if you get into the mode of disease competitions, my disease is more important than your disease and this, that, and the other, then it can be extremely unhelpful. And no wonder then that health people are quite uninfluential when it comes to trying to bring better politics into the debate, because it all depends on if your disease has a bigger voice than my disease, if you like. So that's number one. The number two thing is there is a debate to be had that certain diseases may have a bigger global burden, and I suppose the rationality of the question is that the way to answer that question is to look at the burden of disease, and the things that cause more burden on society, you should get more funding. And obviously NCDs will be there for a long time to come for that. But that's too simple an answer, because of the nature of risk factors and the nature of personal behaviors that impact on the disease experience, as well as the prevention and other opportunities. It may well be that certain diseases, which may have a high burden of disease, do not necessarily justify a high share of public funding. And this is because the responsibility of individuals versus the collective may vary. It may be, of course, this doesn't mean to say we should blame diabetes onto bad lifestyles of people who shouldn't be, who are eating too many unhealthy foods. I'm not going down that particular route. But what I am saying is that let us be real. We are living in a post-COVID world, and there will be more COVIDs. And the idea that somehow we can continue to exist in the way we've been doing really is not helping. And then if you look at the issue from the perspective of developing countries, which have multiple demands on their budget, all sorts of external factors come into play in all that. So I would have thought that the answer to this is not to argue for more funding for this or that, but to say, can we find a more equitable, a more rational, a more humane and moral way in which health, including health research, can be funded? And I don't know what the answer to that is. But I certainly don't agree that just because NCDs are the most prominent global health problem as measured by the metrics of the amount of disease out there, therefore it deserves the most money or more money than other conditions.
Thank you, Mukesh. Margaret, would you mind taking this up from an inequalities?
Yes. Yeah, I mean, I agree with both Iveta and Mukesh. I think, to me, the underlying roots that make some people at higher risk of a communicable disease or a non-communicable disease are very often the same. And from a public health perspective, we should be trying to address those underlying roots rather than just addressing the condition. And I think, to me, the question isn't just about funding. It is about funding, but it's also about public health capacity. It's about policy attention. There's a whole lot of other things that feed into that. And we've been very highly preoccupied with COVID-19 for very good reasons. But even among the public health community, I think we kind of need to take a bit of a step back and say, actually, it's not just dealing with the transmission of the virus. That's very important, but we also need to consider these wider determinants that have made some people at higher risk and that have themselves been affected by the pandemic. So I think that was kind of my central argument, is we need to consider these things in an integrated way. And that sounds a little bit too trite and easy, but it is really important. Otherwise, we will just get this competition between disease interests, and that is not helpful for public health. It's definitely not helpful for the population, and it's particularly unhelpful for the most disadvantaged people who have the highest burden of communicable and non-communicable disease.
Thank you, Margaret. I'd like to ask Lynette about some of the questions in the Q&A with respect to what can we do? We have this huge tsunami of infodemic issues. How do we tackle it? Thanks, Lynette.
Thank you, Professor Varma. So I guess it's a really big question, like just giving you a bit of a taster into understanding, just an insight into the infodemic. As I mentioned before, it's not the first time that we've experienced an infodemic, but through this COVID-19 pandemic, we also have the technology which is allowing us to really spread this information quickly without necessarily verifying it. And this might be, the spreading of misinformation, as we heard before, that definition unintentionally, because certain people might not be aware that this information which has been shared in my WhatsApp group, for example, is actually incorrect. And so in terms of practical steps, well, there are different tools out there. So we do have a WHO Health Alert Service, which is an interactive chatbot with Facebook Messenger. We also have a WHO Viber service, which is another interactive chatbot, which enables you to just get the most accurate information, which I would then highly encourage you to actually share across your social networks and across those platforms. The challenge as well for us right now is that there are conversations that are happening in these closed messaging groups. And that is something that, we're calling the dark social, because, maybe in our different network groups, we have our like-minded friends, but we also might not necessarily have gone and checked these things, but we're thinking about, okay, I really want to help my mom. So someone has said this might be helpful. Well, I think it's really important for us to look at, well, what are those fact-checked pieces of information? I'd highly encourage you to actually first and foremost look at your health authority. So whether it's a WHO website or one of the fact-checking websites, so the Pointer fact-checking network, for example, has so many different organizations across the globe who are fact-checking. And then, of course, the fun Viral Facts Africa initiative, which I shared before, you can find some of these pre-fact checked bits of information. But the other thing that we have to think about is in schools. So right now, or what can we actually do to pretty much build this army? I think if I borrow from Dr. Mukesh's words before, where, speaking about this war, but how do we build this army of people who are actually ready to fight and tackle this this infodemic? And the best way is actually to build their critical skills, their media literacy and health literacy skills. But how do you ensure that there are those feedback loops and so that we can actually do what is necessary, whether it's debunk a misinformation that has already been spread, or better still, if we're teaching the critical skills and the media literacy, we can actually teach people what a misinformation might look like, so that they are actually in a better position to identify it before they are victim to it. And there are many games. So after I finish speaking, I'll pop some things into the chat as well. But there are many games out there which are evidence-based, research-backed games, which are helping people to build those skills to identify the misinformation, so that they themselves, after this gameplay, are in this better position to talk to family about what that experience is like, but also identify it going forward as well. So there's some of the practical steps and tips.
Thank you. And Will, working for PHE, a lot of your work is about ensuring that we get timely information. Any thoughts from you as to lessons learned from COVID?
I think timely information is important, but it's also making sure we get the quality good quality information out there. I think that's come through consistently. We do need to get the information shared, but one of the big challenges is how we communicate the uncertainty in that. So it's therefore sometimes doesn't end up as nice media sound bites, because there's considerable variation. But it's also how we can sensibly facilitate that debate about what it means in a public domain. So it's great that we've got so many people interested in commentating on it, but it's making sure that what the public sees of that scientific debate is positive. It's seen as people looking at the evidence and looking at multiple different ways, and isn't just represented as we can't agree, and that then feeds into some of the lack of trust. So it's a really difficult balance to take in a world where things are emerging so quickly and there's so much uncertainty. But it's making sure we can try and both be open and honest and have that debate, but take the public with us. It's quite what it all means.
Well, on that note, I think all of our panelists have taken us on that journey, and I'd like to thank you all for a phenomenal set of presentations. You've very much got us thinking, and a lot of debate. So what we're going to do is get a list of the different things that you've put in the chat and the Q&A. We will disseminate that to our delegates and ensure that we carry on this dialogue. And in all of these sessions, we hope that we'll be able to continue some of these discussions. We have our next special session, as well as our poster session later on today, and then a whole range of activities for the next 4 days. We hope that you'll be able to join us. And if not, we will be recording most of the sessions on our YouTube channel. I'd like to thank the organisers, as well as our fabulous speakers and our attendees. We've had a lot of debate and discussion on Twitter and YouTube, as well as the Q&As. And so I'd like to close this session with a plea to keep the conversation going. And a huge thanks again to all of our speakers. See you in the next session. Thank you.
Thank you very much, Arpana. Have a nice day, everybody.
Have a nice